Good morning, everyone. I'm Dave Henderson. I think we've all met the course of yesterday, and I'm here with Dr. Christina Borba, and we're going to be talking about research funding. Funding in general, it could include educational funding as well. And so, as you know, Dr. Borba is at NIMH, and so I think it would be appropriate for her to start it off, and I've asked her to maybe talk a little bit about her career and her career path and so on, and then talk about opportunities at NIMH. And so, Dr. Borba, is that okay?
Sounds good.
Okay.
Good morning, everyone. I'll start a little bit about my career and how I got to the NIMH. I actually have known Dr. Henderson now for almost 25 years, if you can believe it. But started off 25 years ago thinking I hated research and that science was not a career for me. And it wasn't until I had an opportunity to be a research assistant that I realized in clinical research with patients with schizophrenia how much I actually really did love science. And I think it's really a theme around good mentorship, having those opportunities, starting really young in that process. Fast forward, I thought I was going to be a clinical psychologist, and my mentor, who's sitting right next to me, told me I would be a horrible psychologist. It was actually the best advice I've received, to be honest, because I spoke more like a public health person. Now, 20-something years ago, public health was not really understood the way that it is today, and I'm thinking, what does mental health have to do with public health? And now, when you think about the leading causes of morbidity and mortality worldwide, it makes perfect sense why mental health and public health really do go hand in hand. So I pursued my master's in public health and then a PhD also in public health, and started my global mental health career probably 14, 15 years ago, and have done a lot of work with a lot of you actually in this room, to be honest with you. And then about 8 years ago, I took a position as the vice chair of research of psychiatry at Boston Medical Center, which is our largest safety net hospital in New England, and really started to understand global with the US in it. The US is global. And how do we think about our patients and the needs of our patients, both within the US and then globally, and what can we learn from each other? And I do see there's a bi-directional learning, I think, after us, and I'm gonna tell you, the NIMH has changed that name to something else, but I'll give you that info in a minute. So let me tell you why I decided to leave an academic career and go to the NIMH. I've upset this man very much next to me with that decision. But I started at the NIMH in September of 2022, so about a year and a few months ago.
Feels like 2 years.
He says it feels like 2 years. I don't know how to feel about that. So let me tell you a little bit about the structure of where I'm at the NIMH, because I think it's very relevant for this group, and then just the structure of funding through NIMH as well. And I really did appreciate our previous speaker talking about Josh Gordon, who actually is my boss, and the changes that are happening rapidly at NIMH, both in terms of work in the US and then globally as well. So I am the director of the Office of Disparities Research and Workforce Diversity. The office sits within what we call the OD, the Office of the Director, which is Dr. Joshua Gordon. When you all have applied to NIH funding or NIMH funding, you apply through a division, right? And we have 4 divisions. So we have bench research, that's not the fancy name, but we have bench research, translational research, intervention and services research, and then the Division of AIDS research. Those divisions manage your grants. And so you've probably have spoken to program officers in the past and all of that. Those are all within the divisions. The office, my office in particular, I always think about it as almost like an advocacy group, in the sense that our job is to make sure that we're thinking about disparities throughout all of those divisions, all the way from bench research to AIDS to global, towards services and intervention. And so when those funding announcements come out, my office is really responsible to make sure that we are really truly thinking about health disparities, global mental health and domestic mental health disparities. We sit on, I now have an office, I started with an office of 3, we now have an office of 12. Also we sit on a lot of trans NIH committees and HHS committees as well. And so some of the relevant things that I want to talk about today that I think would be really applicable for this group. So NIH, about 4 years ago, when we had the new administration, started an initiative called Unite. Unite stands, each letter for Unite stands for a different topic. And the key for Unite is around ending structural racism. And for the NIH to come out with that statement that says, not only do we have a problem inside the NIH in terms of structural racism, we also need to think about externally. And really, what does that mean? It means the workforce of NIH needs to be more diverse. So when all of you call program officers, the program officers need to look like you, need to know what type of research you want to do, need to be experts in that science. Unite also is thinking about bias in the review process. There was an announcement that came out that in 2025, the review process will now officially change. And one of the key components that have been eliminated is environment. Now, I have been the beneficiary of that environment score because I have been at Harvard and I have been at Boston University. I would get an automatic like A+, right? Those are top-notch universities. What happens if you're in a historically Black university, a tribal nation, a low and middle income country? You then get scrutinized in a way that I didn't, because I was at Harvard and I was at Boston University. So there has been now a huge committee to recognize that the environment doesn't matter. It's your science that matters. NIH is funding your science. They're not funding what institution you are from. And so the environment has now been eliminated, right? And this will start in 2025, so there's some time, because we have a lot of work to do to train our reviewers. To be a reviewer now at NIH, you have to go through bias training, and it's pretty significant. I have been the recipient, as I'm sure all of you who have had summary statements, where you been asked, why don't you have a white comparison group? And you're like, well, that's not actually my research question. I don't need a white comparison group because that's not actually my question. And so a lot of those changes are now happening within the NIH in terms of this recognizing the bias in science and how we do continue to keep funding the same people and the same institutions over and over again. So that is Unite. The Compass Initiative is a huge, I guess, pilot, you can say. It is the first time NIH, Josh Gordon is the co-chair of Compass. It is the first time NIH is funding community-based organizations, not funding an academic institution. And so it is a 10-year grant, which that in of itself is huge, in really funding community-based organizations that do work in the community, know what the community needs, and then those communities decide who they want to partner with in terms of an academic institution and not the other way around. 25 of those got funded in September, and we will be tracking that. So there's some confusion, and I was confused before arriving at the NIMH. What happened to global mental health? And so at the time, my office was both global mental health and health disparities together. And it got separated. So now it's an office for just health disparities, and global mental health is now a center that sits under the Division of AIDS Research. What that communicated, unfortunately, to the public is, oh, NIMH is only interested in AIDS research. And that is actually not true. It sits under the Division of AIDS Research because of the infrastructure that the division has globally. But by no means do you have to only submit AIDS research. And so some of the work, because of my global experience, I sit on a lot of the global committees. One of them that I sit on is reciprocal learning, which is what we're calling bidirectional learning as well. And so really thinking about how can we learn more from what other countries are doing? How can we apply it to the US? What has the US done that we can apply overseas? And so the Center of Global Mental Health is, although sits under the Division of AIDS Research, please know that you do not have to submit an AIDS grant for sure. The NIMH is celebrating its 75th anniversary, which is quite remarkable. We had our big launch event in September, and I'm going through this beautiful handbook, and what do I see? Chet Pierce. So NIMH has recognized Chet Pierce as part of the history of NIMH. A few years ago, after a lot of incidents that were happening in the United States, including the killing of George Floyd and what was happening with COVID, NIMH developed an anti-racism task force. And one of the recommendations of this task force was that, I know we're celebrating our 75 years. It wasn't all like rainbows and roses or whatever the American saying is. I don't know what it is. But that we need to acknowledge our history, and we need to acknowledge what NIMH has participated in over the past 75 years. And so Chet Pierce is highlighted there for a lot of the things that you talked about, and really pushing the boundaries and thinking about our workforce as well within mental health. The U.S. Surgeon General has come out with that we are in an epidemic of loneliness. And so I sit on a U.S. Surgeon General committee around loneliness and social connectedness. That has become a huge priority, and really thinking about there was some data that I was just, actually right before I boarded a flight here, I was in that Surgeon General meeting, and the data was presented that loneliness has the same physical impact as smoking a half a pack of cigarettes a day. And I was just like, whoa, that's profound, right? And given the disruption of COVID on our families, on those who lived together with their grandmothers and aunts and uncles, and that whole disruption, this has become a huge priority, and not just within the US, but globally as well. NIH also was one of the leads for climate change. So today, this past couple of days, we're talking about climate change. My colleague from Boston University talked about the Research Coordinating Center of one of these grants. I also sit on the Committee of Environmental Justice, and really looking at climate change as a health disparity, and where you live and what you look like and how much money you have. Climate change will impact you completely different. And so there is funding announcements right now in terms of climate change, and NIH has taken a huge lead in trying to really start gathering that science. And so let me tell you about the priority areas of NIMH, because I know everyone in this room is wanting to know, like, what are we interested in funding? There is a shift. A lot of people have asked me, why did I take this job at NIMH? Why did I leave academia? I had a very productive academic career. And I'm very honest about this, and I've said it, within NIMH and NIH, is I was sick of complaining about how bad of a job they were doing in this space, and that I at least wanted to be part of the solution. And I have been pleasantly surprised at how much they are taking this very seriously in terms of thinking about race and our environment, social determinants of health. And so much so that I hired one of my new hires that just started their expertise is in structural racism. That sends a huge message, right? That I hired someone whose expertise is in structural racism. So youth mental health, probably one of the biggest priority areas right now at NIMH. Specifically, we put out several funding announcements on Black youth suicide. CDC came out with their numbers in 2021, and all of our minoritized groups their numbers are, it's shocking. And so Black youth suicide, sexual and gender minority, transgender, and specifically for us, American Indian, Alaska Native, I mean, these numbers are really on the rise. And so I also sit on the suicide prevention team and really thinking about what additional funding announcements we really need to think about. So suicide prevention, youth mental health, social media. Also something, we're getting a lot of pressure from Congress about social media. Now, I am of the mindset, although we need data to support this, there is a role in social media and digital technology. I'm not saying that there isn't, but we really need to think about what is that role, where does it become beneficial, and what happens when there's bullying and all of these other implications on social media. And so that has now been a big priority area for us. Community engagement. I was at a huge event with 500 faith-based leaders in DC, and I talked about our interest in community engagement, and I think they all fell on the floor. And they're like, the NIMH is really interested in community engagement, and the answer is yes. And so my job recently has been pushing the appropriate funding mechanisms to do community engagement well. How do we get the voices of the community at the scientific table from day one? How do we get people with lived experiences to help and decide what are the most appropriate research questions, right? Because we can sit around our offices all day and think we know what's going on in the communities, but we don't. And then also part of the name of my office is also workforce diversity. So it's really expanding, what is the next generation of scientists? What do they look like? What type of science are they bringing to the table? And so we are doing, and there is a little bit of a joke at NIMH that I do not want to see that map anymore of where we fund our investigators, because for the United States, it's the coast. It's California, and then it's the Northeast. Last time I checked, there are institutions all over the United States and all over the world. So we are now, there are a lot of funding mechanisms out there to really thinking about expanding that workforce as well. So you can reach out to me anytime. I know I don't sit in the Center of Global Mental Health, but those are my dear, dear colleagues. And so you can reach out to me directly, and then I'm happy to do what I've been calling the warm handoff, which is the clinical term that I learned while I was at BMC. I do warm handoff. So I do a lot of technical assistance, really trying to understand what you're interested in and who is the best program officer for you. And get you primed and ready to meet with your program officer. So that is my job. That is the job of my staff. And so don't hesitate to reach out. How's that for not being prepared?
Excellent. You killed it. Before I do my unprepared speech, I will have a question. Just thinking about like in NIH, NIMH, and the changes that you highlighted, because one of the issues is that it's like a club. It's a club.
It's a club.
So meaning that few people get most of the funding.
Mm-hmm.
So do you think that the changes that you just highlighted are going to impact that club?
Yes. And let me just tell you, I'm only allowed to tell you things that are public facing. So I can't share you secrets that are not public facing. But the answer is yes. There is so much work being done, and there is this acknowledgement of the rich keep getting richer. That is the statement that's being made. The rich keep getting richer. And major things have to shift. One example that I can talk about is that NIMH specifically developed a registry. I can't call it a database. It's a registry. A registry for reviewers. So I'm happy to maybe send it to Senite, and maybe we can blast it out to the attendings here. It's a registry to serve as a reviewer for NIH grants. Now, back like not that far away, you could only serve as a reviewer if you had previous NIH funding. You could only serve a reviewer if you were at a certain academic level, but there's inherent bias in that, right? So what NIMH did was basically saying, we just want your expertise. And if you have not had NIH funding in the past, we don't care. If you are at the postdoc level, we still want you. And so there's this registry that you can sign up and you can put in your credentials. You can talk about like what areas of expertise you have. And then when certain grants come in, we actually are going through that registry and pulling people who have that expertise to sit as reviewers. That's also a great opportunity to see what the review process is like and to be part of that learning as well. So we can send that out. The other one, funding mechanism that has come out is looking at, so as academics, we do a lot more work than just seeing patients and doing our research. We serve on tons of committees and teaching and mentoring, and the list goes on, right? What NIH recognized is that there are certain people that falls more on the shoulders of than others, and we call it the minority tax, right? So if you come from an underrepresented group in science, you are sitting more on those committees, you are mentoring more of those people. And so they came out with a funding mechanism that now says, we will pay you for mentoring. The moment the NIH pays you for something is the moment the universities start paying attention, right? So if the universities are like, oh wow, the NIH is now going to pay for all my mentoring, so now maybe we will recognize that in the promotion process, right? And so, and other mechanisms have come out for, you're only eligible if you've never had NIH funding in the past. That's now the eligibility criteria. You're only eligible if your institution has had this little amount of NIH funding. So if they've taken the like, well, you're only eligible if you've had previous grants, and they flipped it. Because for what you're saying is, if we kept doing it the same way, we're just funding the same people over and over again. So those mechanisms are out. I was told not to do slides, but I do, but I do have, and I can also send to Senite, there were so many of these opportunities that I was getting confused that I asked my staff, can we please organize this? So there's 3 slides that literally have every mechanism out there when it comes to workforce diversity or expanding the workforce. One of them is the R13, which I've been sitting in this conference thinking we could have done this, which is NIMH uses the R13 to fund conference attendance for people who are underrepresented in science. And so that R13 comes directly out of my office. And so this conference, we could have used that mechanism to fund people to come. And again, you have to be underrepresented in science, and NIH has a really strict definition of who those are.
What's the timeline? Like, how far in advance do you have to apply for?
So yeah, I'll give you a good example. We have someone who's applied for a conference in March, but our council is in January, and it's cutting it a little close.
Got it.
So to answer your question, and more, and that's all coming out of Unite. So like I said, each of those letters stand for something else. You can literally just Google Unite, NIH, and it'll come right up. But E for Unite stands for the extramural workforce. And all of those initiatives are coming out of that E subcommittee because there's been this massive awakening of wow, we're really biased in who we fund, right? And what we determine is good research. And so we're not saying we want rigor, obviously, but part of that review was also about like, where are you from and who's mentored you and all of that. There's more stuff coming, and so as they start to come out, I can start sending it out to everyone. But you can always just email me as well, and we can, have discussions. But it is true that there has been this. I was a little surprised how much NIH has now realized, and we're getting a lot of pushback. Don't get me wrong. There's a lot of people who are pushing back, who are saying that diversity has nothing to do with science. We're getting a lot of pushback about you guys are spending way too much time and way too much money thinking about these things, that how we were doing it before was just fine. And NIH is pushing right back. So it's been an interesting time, I think, for NIH. NIH just has its second female director in the history of the NIH. She was approved by Congress. She actually is from Boston originally. She was the head of NCI, so it's the National Cancer Institute. But the only second female to lead the entire NIH. NIH is even longer than that. So NIH has 27 institutes, and IMH is one of them. She is the head of the whole thing. And there's a video you can where she's like, saying hello. And her priority is equity. That was kind of her first statement, was thinking about equity in research and equity in workforce. So I'm really interested to see what happens under her leadership as well.
Oh, great.
Okay, your turn.
Thank you. So I'm going to describe something very different. I don't work at NIMH. I've had NIMH funding for more than 20 years, both in research as well as research training grants. But most of my funding for my research career has come elsewhere. And I'll tell you, like I started out like many of you, where I did research like nights and weekends, no funding, did chart reviews, various sort of things. But there's some early grants that are really important. That like even I was just thinking at Boston Medical Center, we're not even our young researchers are not even applying for. And one in particular, it used to be called the NARSAD, but it's now, I think it's the Brain and Behavior. Yeah. And it's a fantastic early career grant. And I looked last night, and there's no restrictions, as far as I can tell, on where you are. Could be, and you just have to be at an institution that can submit a grant. And it's the Brain and Behavior. There's an early career award, and it's about, I think it's like $35,000 a year for 2 years, and you propose a modest research project that you can do in 2 years, and with that level of funding. But it's a great start for young people. And then they have mid-career, seniors, and that sort of stuff. It goes up to like the seniors get like $100,000 a year for 2 years, and so on. But it's a fantastic mechanism. They have funded hundreds of millions of dollars of research over the last, 30, 40, 50 years or whatever, how long ever it's been in existence. And it's usually, like at Mass General, that was our first grant that people would apply for. And it was just an automatic thing. Everybody applied for it. And you could get two in 2 early careers, and then you move to the next level and so on. But it's like such a basic thing that it made me think that we as an organization really need to lay out the steps for people. Here's a bucket of things that you should consider when you're at this stage, and then work your way up. Another great example is that there's some Fogarty grants. Fogarty is a part of NIH, but it deals with the international or global portfolio in a sense. And they have D43s, which we will be applying for one. I think Layla mentioned yesterday, right? We're going to get that D43. But there's all.
And NIMH can co-fund a
Yeah,
Fogarty grant.
good tip. We're all over that. So there is there is currently a Fogarty grant called HBNU, Harvard University, Boston University, Northwestern University, and there's another in there. New Mexico. New Mexico. Thank you. I always forget New Mexico somehow. And it's health in general. It's global health. But we are actually we have a group of covering psychiatry and mental health, and so I'm one of the mentors, and I usually have 3 or 4 people a year, and so the Fogarty grant is for young people, in developing countries, lower middle income countries, are like, which is different than our T32 grant, research grant, which is funded by NIMH, but it's for U.S. citizens, and they go to countries that we have collaborations with. But the Fogarty it's exactly opposite. So we can fund young people here. It's a 1-year a fellowship that you spend a week at Harvard in Fogarty training, and then you could spend up to 2 months, like I think, with your mentor in one of the 5 U.S. institutions, and then you go back to your country or the country you chose to do the project, and you do your project, and so on. So it's a really nice way to get a year of good funding, do a great project, and then get connected and start networking, and perhaps move on to other things. Now, I think that one of the most important things for young investigators is, as Christina pointed out, like, have a good mentor, and hopefully that person has access to funding to help kind of support and bridge, and when there are gaps and that sort of stuff. But I think that's actually really important. Now, the other thing, and I have had a conversation with Layla after a couple of wines last night, and we, but you don't remember, you didn't have the, I had the wine.
You're on video, right?
That's all right. Hello, hi, Mom. But it actually made me realize that first is, like, number one, like, there are actually a lot of foundations out there. We just have, they're not going to come to you. We just have to find them, and some of them are very specific to your country, to a cause, and so on. But then I realized, wait a minute, we have the internet. And now we have AI, so we could utilize these tools to like we have a development office at our hospital, and this is my point. Like, our development office could tell you, because the software they have, individual donors or foundations, who do they give to, how much they give, when's the last time they gave, what causes, blah blah blah, and so on, and we can get that information. But the information, a lot of it is available on the internet, and so again, for me, a good portion of my funding has been with foundations. Some in IMH, and then another portion has been with pharmaceutical companies. Two strategies I had, which I think helped, like, support our research program and, and so on. But one strategy was that I would wrote a lot of like investigator-initiated proposals and some, got funding from companies. Obviously there was a mutual interest. I'm using their compound to do a study that, goes, phase 4 study. They've already have, their indications for their drug, and we're looking at different other aspects that the drug could be used for, or that sort of stuff. So that's one piece. And then the second piece was that we also um, became sites for large multi-center studies. And it's been kind of baffling to me, why this hasn't taken hold in Africa as much. Like pharmaceutical companies, they have big money and they have novel compounds. And I always like to do those kind of studies because I'm in at the early stages of understanding mechanisms about a new drug or new approach. And if the drug is approved, then I know all about it already, way before everybody else and stuff. So I've always liked that. But the fact is that they do a lot of, they have a lot of sites all over the world, but very few in Africa. They go to Asia, they go to, Eastern Europe, like you wouldn't believe, and so on. But there is an opportunity. I don't know, I assume in like HIV research, they're doing their trials here, right? Anybody, right? Right. So why are they not doing mental health trials here, right? And the reason, again, for me, that was a strategy because, again, it was educational. It gave like state-of-the-art access to our patients. But number 3, it allowed us to have funding to support our research team. And oftentimes there were some margins in that, meaning that we were paid to do the project, but we actually, we paid our personnel and all of our expenses, and we had money left over, and then we could fund pilot projects and that sort of stuff. And then the last piece, which is what really the conversation with Layla was about, is our approach to finding donors and the mechanisms for doing that. And it's a challenge to some degree, but there are methods that could be utilized in order to, like every country, wealthy or poor, has wealthy and poor, right? And so it's possible that every country here represented here, there are potential donors in those countries that if they were made aware of what you were doing, what you were interested in, may be willing to support you. And so, but there's a science to it. The mechanisms, as I said, we have a development office that really helps us with that. Your institutions may have that, but they oftentimes, like when we first got to Boston Medical Center, our development office told us, oh, there's no donors in mental health. And I said, well, I just came from Mass General. We were getting 15 to 20 million a year in donations for psychiatry. So there are donors in mental health. You're not finding them. Now we have a development office that are, very much in tune and constantly looking for opportunities and so on. And so, thinking about who we are here and what can we do to equip everyone here with the skills in order to raise funds for their research or their training programs and so on. So I think this is a bigger discussion, and I'd be curious for what people's thoughts are. But it just reminded me, like, oh, yeah, I think we really have to pay attention to this. And just like when applying for an NIMH grant, what does it take to do that? Like, what resources do you need to be able to be competitive? Like, I don't like those grants, right? They're tough. They're tough to get. It's like, but I think the NIMH represents actually a small percentage of the funded research. Am I right?
The statement is we are the biggest funding agency of mental health research
Yes,
worldwide.
but collectively, I like that statement.
Thank you.
But collectively, if you put it all together, it's a small percentage of the funded research.
But I do want to, you made a good point. NIMH, yes, NIH, sorry, not NIH. When you guys open up a program announcement, a funding announcement, you'll see the different, what we call ICs, the institutes who signed on to that funding announcement, right? So that means if you don't see NIMH listed, that means we didn't put any money in the pot. But if you see NIMH listed, that means we're interested. We now are putting out research capacity grants for exactly that reason, with an acknowledgement that to get an NIH grant out the door is like pretty significant, right? And even for the very large institutions like the Harvards of the world, like we keep talking about, we have machines, like they're like machines, they just do it. That puts other institutions at a disadvantage, right? And so, so now there are mechanisms that we will pay to build the research infrastructure at your institution to then be competitive to apply for NIH funding as well. And that's, again, an NIH level and an NIMH. And that's really my job, is to sit in all these meetings and to be like, oh yes, I love this idea. And then I go back and I make the case that we should sign on to this. And so when you see NIMH listed, that means we are interested in that grant mechanism as well.
Yes.
Can you tell me more about that, the research capacity?
Yes.
And then
I-
follow up.
So depending on the actual mechanism, it basically, the requirement would be, if you haven't had X amount of money from NIH, or you don't have like a grants management office, or there's all that criteria, then you're eligible to apply. And that grant would then give you money to then hire the people that you would need to like manage your grants and all of that. So it's the infrastructure of putting a grant out the door, not the actual science for that stage. Does that make sense? Because I think about the work we used to do at the University of Liberia, like there was no grants office, right? They would be perfect for something like this, right? Because it's actually NIH being like, we recognize that you don't have the actual people trained to know what half of these acronyms mean. And so we're gonna fund that first, and then from that, you can then apply for scientific grants. So it's a research capacity mechanism and not a scientific grant.
And we probably have old grants that we
Probably.
wrote for exactly that. So,
Question? Oh,
Yeah, sorry. Thank you. Thank you, Christina and Prof. Henderson. My name is Vincent. Sorry, I didn't introduce myself earlier. I'm from the U.S. Embassy in Pretoria. So I work with Sophia. Look, I'm just interested listening to what you're talking about now, Christina. To be honest, we can change the way we look at doing research in Africa on low to medium income countries. But if we do not prepare the ground, then again, for NIH type grants, it's going to be lost. So there needs to be a deliberate effort to capacitate the people, and targeting those people becomes very, very important. I think you mentioned one of the strategies that NIMH is undertaking, which is to say what is the next scientist and what does it look like and how do we get there. I think that is important. Not to overlook also historically disadvantaged institutions, because they do leave the context, most of the people. They have been historically excluded, but then the science is actually with them. It's the capacity to apply for and manage grants, which are of the nature of NIH or NIMH in particular. Then what we see more and more on the ground is coordination becomes even more important so that we get a bang for our buck to duplicate efforts between the Americans, for example, the Germans and the British, whosoever is also funding, this type of research. Is you find that the scope is almost always the same, the focus, and again, the funding goes to the same people, but being able to map who's doing what, leveraging what has been done, so that you get more impact for the American dollar is actually very, very key. And we can help do that through the embassies. Then the last thing is positioning for impact. I was very encouraged listening to you to say you are putting in communities at the front. So if you fund research and you get these publications in Nature, it's fantastic, it's good, it's contributing to the knowledge base. But ultimately, when it comes to health, we want to impact health service or healthcare, or so the impact should be at a public health level, right, to the person. So even for sustainable funding, because the governments would want to know, if I put in this amount of money, what is it going to translate to? If it translates to a paper, it's less likely to be important. But if you generate interest and a track record of saying, okay, these are the policies that came out of it, these are the guidelines, and this is how it is impacted and translated, how we look at mental health and implement it in the country. I think it needs to be deliberate as part of setting up your research project to say, this is how we're going to measure impact. Thank you.
And I always say dissemination is a science, right? And so last time I checked, my mother is not reading a paper in JAMA, psychiatry. And so, but that dissemination, and what lessons we learned from COVID on how bad we disseminated public health information, right? And so that is a science in of itself of how do you communicate science, not back to just the communities, but ministers of health and our Congress and Senate and all, like they don't care about p-values last time I checked. And so that in of itself is a whole science of taking evidence-based treatment and communicating that back to the communities who really need it. And then Olivia had her hand up. Olivia, can you please tell the group how we know each other?
Good morning, everybody. So I'm Olivia Machawane. I was at the NIH, and that's how Dr. Borba and I know each other. We were in the same building, same floor for a little bit of time.
And met over Zoom.
But we met over Zoom, and so we met here for the first time. But thank you so much for this talk and just sharing about the opportunities that are available. Speaking from a perspective of having a little bit of insiders, knowledge of the NIH. First of all, the NIH is really trying and really trying to listen. I know that there are opportunities even to contribute to how the calls for grants are even structured, like what are the important things, like the previous question was asked, to include in that criteria. Is community engagement important? Is ethics important? Like these are some of the things that need to be included when you submit a grant. So my question, Dr. Borba, was around, there are certain funding mechanisms through the NIH that will specifically say, like for example, H3 Africa. So I'm from the psychiatric genetics kind of background, and they will be very specific as to it needs to be an African investigator who leads this grant application, and you can collaborate with international, you can choose to collaborate with a US investigator or anywhere else, but it has to be African-led. And the institution must be an African institution that gets the money that can be able to build the infrastructure. So my question was around NMIH, if there are, I've seen calls around investigators need to be from low and middle income countries, for instance, and I was just interested if you could speak a little bit towards that, because I think that's important. We've mentioned the Harvards and all of those institutions, and sometimes people tend to think, oh, I have to collaborate with somebody at a US institution. I've been explicitly told by program directors, that's not a thing. You don't have to collaborate with someone. You don't have to force yourself to collaborate with someone at Harvard just to get a grant when that's not appropriate for the research, you know? So you can still get the grant. I thought you could speak a little bit about that.
So that's absolutely true. So again, back in the day, which was last month, it was definitely this idea of like, I need a big name on my grant, right? And we've called that bluff now, right? And it's actually funny now when we're looking at it and we're like, you just slap that person's name on because you think you're going to impress us. And there's been a switch now. And so this idea of putting big names for the sake of big names, we can kind of see through it, and we're changing, and we're really more concerned about the science. There's been a huge refocus on the science and what is the question and what public health impact is it going to have and how is it going to further the literature and the health of people. And if it means there's no one at Harvard who can do this, great. We don't want Harvard on that grant, right? And so a lot of the training of our reviewers is based on that, of like, we have to stay clear away from the big names and the big institutions if they're not actually contributing. Now, it's not to say that there's not someone at Boston University who could add a huge value to a grant, but we have to be explicit about that now. And so, and if there's no one, and if you're like, we can do this and we can do this ourselves, absolutely go for it. That's the message now,
Yeah,
right?
and so the question is, how long will the message catch up to the actual practice? Like, how long will it take? Because you said things are being implemented in 2025, and like how long?
Yeah.
And you have to change all of the review process, all the reviewers,
it's slow.
their mindset, because
It's true, because when I arrived just a year ago, the email came out that says, be prepared for FY25 like funding concepts. And I literally was like, is that a typo? I'm in 2022 and we're already, so right now we're preparing FY26. So think about that. Like what you guys are gonna see of the things we're talking about now is in FY26. So that's October 1st of 2025 if the US government is open. Lapse of funding. I can't say government shutdown. We have to say lapse of funding. So it's so slow. Yeah. It's very, very slow. The good thing is when I arrived, a lot of this was already happening. So it's really started with the new administration that came in on board, and it kind of all exploded. So it is going to take time. So I'm not saying like tomorrow. And a lot of the funding mechanisms that I'm hoping will hit, you guys will see in 26.
Thank you. I think
we're out of time.
Done?
Oh, Layla has one more.
One more. Okay. Okay.
Thanks. One question. Christina, thank you. It's very, very nice to hear that there's this changes that are happening. So my question is around, I think there's a lot of researchers in this room and a lot of researchers that I know that don't even apply to the NIH. And I like to think of it as the grass ceiling, because South Africa is always seen as like greener pastures. And why aren't they just applying? We're ready for them, but there's very real reasons besides reviewer bias that people are not applying. And I was wondering whether the NIH and NIMH would think about doing a study of established researchers who don't apply for grants in Africa, and emerging researchers and people who have the potential, and say, what is stopping you? Because I think you'd find really interesting answers that go beyond reviewer bias and infrastructure in my...
Okay, so really quick, there was what's called an RFI, a request for information in global mental health. Did anyone respond to that RFI in this room? You did? You did? Okay. we take that seriously. Like, we actually do a full-on data analysis on that, and that actually informs what we do next. So when you guys see a request for information coming out of the NIH, please respond. That's number one. Number two, I will bring that back. And number three, all the emerging young investigators who are presenting this afternoon have been tagged in my book already, because I already plan to follow up with each and every one of you as well.
That's it. Thank you very much. You sure. Boom.